Everyone. This is Ranjit, one of the neonatal consultants from Butterfly Hospital in Hyderabad. So, taking on to the next session from our previous module, see, going on to the modes of ventilation. If you have attended my previous session, so basically we discussed about the basics physiology of ventilation, mainly stressing on the importance of compliance, resistance, and dead space, elasticity of the lungs, and what is the inspiration and expiration involved, how the gas exchange happens, what are the parameters. So going from there, once we decide this baby needs ventilation, what are the modes that we are going to decide, and what are the things like what are the differences in each of the modes that I'm going to touch in this session today. So feel free to ask any questions in between, because sometimes it can be confusing, the terminology. So as we decide, one of the main reasons, once we decide to ventilate the child mechanically, our main aim is to achieve adequate gas exchange, which means CO2 clearance and oxygenation. But at the same time, as a physician, our clinician, our main role is to minimize the ventilation-induced lung injury. Okay, because in this newborn, if any lung injury happens, inevitably with artificial mechanical ventilation, some injury is going to happen. But if we take all the precautions to prevent this ventilation-induced lung injury, we can prevent the long-term complications of lung injury for these babies. As we all know, especially the premature babies and the babies who are very sick needing ventilation, the lungs are so immature and more fragile. The more stress these lungs are going to go through, the more inflammatory changes that are going to happen, and the risk of bronchopulmonary dysplasia and chronic lung disease. So, terminology, when we are going to choose the mode of ventilation, we're talking about 2 or 3 different types of ventilation that we generally come across. What is the primary and most common mode used is pressure targeted or pressure controlled ventilation. Next one is volume targeted or volume controlled ventilation. So, and the combination of these both, which we call the hybrid ventilation in the latest generation ventilators, which we come across now. So, when we say pressure targeted or pressure controlled, both are very similar, both are same, different terminology, but different ventilator makers like Draeger, SLE, Macket, Scanray, whatever we name them. People name it differently, but mainly as a physician, we decide the amount of pressure to be delivered to these lungs. So ventilator delivers a flow of gas until the pressure set by the operator is delivered to the baby. So the flow is controlled by the pressure set. Until the desired pressure is achieved in the lungs, the ventilator delivers the gas. And same time, the flow also has to overcome the resistance of the airways and the lung parenchyma. So if we have, for example, you have a stiff lung, okay, the same pressure, same amount of flow might cause more injury to the smaller airways, and also need more flow and more pressure to more flow to achieve the desired amount of pressure in the small stiff lungs. For example, severe RDS you have, okay, for example, so you are setting a setting of pressures of 20 of BIP. So you want to set amount of flow to go into. In the old ventilators, you need to set the flow, but almost 90% of the new generation ventilators, the flow is automatically controlled by the ventilator machine by the settings you make. Here in pressure targeted ventilation, the flow that delivers to achieve the desired pressure can actually cause damage to the lungs depending on the pathophysiology underlying it. So, for example, take a baby who is just born, preterm, RDS, 28 weeker, no steroids, 850 grams, septic, mother have prolonged rupture, baby born in sepsis, very stiff lungs on the X-ray. You want to ventilate this baby. Okay, so you started with pressure controlled ventilation or pressure targeted ventilation. You set a pressure of 20. To set a pressure of 20, ventilator gives so much amount of flow because lung is so stiff. To achieve the desired pressure, the ventilator has to give the flow so much, so the lungs can actually, one thing, it can cause pneumothorax. Second thing is can cause pressure damage to the lungs. The more these lungs need more and more flow to open up. Same thing. Okay, you started the ventilator, you've given the surfactant. Suddenly, the compliance of the lung changes. Okay, the lungs become easily open, like the alveoli opened up, and the lungs or the compliance has suddenly increased because of the surfactant administration. If you continue the same ventilation settings for this baby, the same amount of flow goes through, and the risk of pneumothorax doubles up. Okay, so for the desired set of pressure, the flow can alter the amount of volume of the lung, both causing the volume trauma if you are overinflating it, or atelectasis if you are underinflating it. So one of the main drawback of pressure targeted ventilation is due to this. When you go to the volume ventilation, here the ventilator delivers the volume set by the operator, not the pressure dependent. So we tell normally a neonatal tidal volume is in a normal size lung is 4 to 6 ml per kilo. So we normally start around 4.5 to 5 ml per kilo. So take 5 ml per kilo and average starting volume ventilation if you want to do the volume ventilation. If volume ventilation, you say, okay, I want 5 ml per kilo tidal volume for this baby. So when ventilator delivers the volume, the pressure required to deliver that volume varies by each breath depending on the ventilator you are using. In volume targeted ventilation, the ventilator will either increase or decrease the peak pressure to deliver the volume set by the operator. So based on the compliance of the lung and the resistance of the pulmonary unit, the ventilator adjusts the flow and the pressure to deliver to this particular lung, depending on the compliance, resistance, both. So physiologically, if you think more, it seems to be more gentle ventilation. And as a clinician, once we go on to volume ventilation, we don't have to do much. Once you set the ventilation settings done, the ventilator will take care of it. Okay. And clinically and in the research, evidence has shown that volume ventilation to reduce the risk of bronchopulmonary dysplasia, reduce severe IVH, because the CO2 clearance is so well controlled, because you're targeting the tidal volume, indirectly you're targeting the minute ventilation, the CO2 clearance. As we all know, hypercapnia, the high CO2 in the body, in the first 2-3 days of premature infant, high risk of intraventricular hemorrhage. Or low CO2, hypocarbia, in the first few days of life, high risk of periventricular leukomalacia because of cerebral poor perfusion. Both hypercapnia and hypocapnia are dangerous to this baby. By volume guarantee ventilation, the chance of going hypercarbia or hypocarbia is relatively less compared to a pressure ventilation. Though we have something that we need to take care of when you have volume ventilation. And in the evidence, it also showed duration of ventilation has been reduced, risk of the incidence of pneumothorax was less, and overall the mortality in preterm infants has come down by using volume ventilation in the over the last decade or so. Okay, then next comes to the hybrid ventilation. Hybrid ventilation is a combination of pressure ventilation plus volume ventilation with the new advances, with the new flow sensors, compensating for the leaks and everything, which I'll go through one by one slowly. So one of the crucial parameters which controls the phases of mechanical ventilation. So when we say mechanical ventilation, we have two phases, inspiration and expiration. So three or four things that we all need to know. One is trigger, synchronization, limiting the flow, and cycling. So what is trigger? Trigger, which controls the initiation of inspiration in synchronized modes of ventilation. So then comes to what is synchrony. Synchrony means we want the ventilator to deliver the breath when babies started the inspiration. So you don't want the ventilator is giving a ventilator is in the inspiratory phase and baby is in the expiratory phase. Yeah. So basically synchronization with the newest ventilator, which senses the flow from the baby by using a small equipment called flow sensor. Through the flow sensor, it detects the baby is in inspiration or expiration phase, and that synchronizes with the ventilator synchronizes the breath along with the baby's breaths. That is the most important part. At the same time, you need to know what is a trigger. So trigger is the amount of flow that is required for the sensor to sense that there is a breath happening. Okay. Sometimes even small things like humidity in the ventilator tubings. Okay. External nurses and doctors moving the ventilator tubes, or too much secretions in the ET tube. All these things can mimic the initiation of respiration by the baby, but baby might be actually in the expiration phase, and the ventilator thinks that baby is in inspiration and provides the breath. So to avoid these confusion, the trigger setting of the trigger sensitivity on the ventilator is quite important. So whenever you're using a synchronized mode of ventilation, which nowadays is become a norm and also a default mode of ventilation, all babies should have a synchronized mode of ventilation, because it makes sense for us to, the baby is taking a breath, you have to support that breath. Yeah, so that the baby doesn't fight with the ventilator. The baby fights with the ventilator, more risk of IVH. So we just have to be making sure the synchronization happens perfectly. And then the trigger. The trigger, you don't have to be too low, so that even small humidity in the ventilator tubings can trigger. You don't want it to too high. You don't want the baby to take around 7 ml per minute to trigger it, the flow. So every ventilator give you an option of trigger. Most common used flow sensor trigger is 0.0.2. The lowest the trigger, that's the better, making sure that the nursing staff, making sure there is no water in the, no humidity or water in the condensation in the ventilator tubings. Okay. Triggering controls the initiation of inspiration in synchronized modes. So flow sensors, which will detect a small movement of gas initiated by the patient's spontaneous inspiratory breath and may be used to trigger the ventilator. Most ventilators use flow triggering. So almost all the new modes of ventilators, the new generation ventilators, use flow as a trigger rather than the pressure. There are also other triggers that are used, something called NAVA, where there is a sensor placed in the esophagus. From there, the movement of the chest triggered by the sensor, and then the ventilator delivers the breath. It is more synchronized probably, but it is more invasive as well, which is not routinely used in the newborn babies. And trigger, as we said, should be appropriately and optimally for different babies of different weights, depending on the size of the baby. Smaller the baby, the lower is the trigger sensitivity, lowers the trigger, and which means the sensitivity of the trigger should be very, very high. The bigger the babies, the trigger sensitivity is not so high, because you allow the baby to breathe a little bit for it to trigger the breath. So what is a flow sensor? So basically, if you have seen ventilators, it is something like this. So in the new generation ventilators like SLE, Traeger, or any new generation ventilators, it is as close to the baby as possible. So for example, the baby here takes a breath, or in the inhalation or expiration phase, the flow sensor here has to detect whether the baby is inhaling or exhaling. Imagine this flow sensor is somewhere here near the ventilator. It takes a lot of effort for this baby to trigger this sensor, which is placed to be here. So if you want to go more synchronized modes of ventilation, or if you want to give volume mode of ventilation, the flow sensor should be as close to the baby as possible. So the most of the new ventilators have got this flow sensor, which is disposable, and it is separately available, which can be attached to the ventilator tubings. It comes between the end of the ventilator tubings and between the ET tube. Okay. But the one of the common ventilators that we all come across is MECMS ventilator. Flow sensor is inbuilt, or even the scan ray ventilator. The flow sensor is inbuilt in the ventilator machine. That means the flow sensor is somewhere here. So that's why we say these ventilators might not be suitable for very, very small babies, because baby might not be able to generate that much flow to trigger the breath all the way from there to there. Okay. It might be okay for bigger babies and children and adults, yeah, for volume ventilation. So if you're using volume ventilation, it is important to have the trigger as close to the baby as possible, especially if they are very small. Next comes to cycling of the breaths. So cycling controls. So when you set the ventilator inspirator time, expiratory time, the cycling controls the initiation of expiration. Inspiration controls the initiation of expiration. Ventilators can be set to cycle either by time cycle or flow cycle. Okay. When you say time cycle ventilator, as a clinician, we decide how much the inspiratory time we allow for this baby and how much expiratory time we allow for this baby. For example, most commonly, we start a rate of 40 per minute, which is more physiological for most of our newborn babies. So 40 per minute, 40 breaths per minute equal to 1.5 seconds for each breath. Yeah. So out of 1.5 seconds, you have to decide how much time you want for the inspiration, how much time you want for the expiration. General starting rule whenever you're starting a ventilation for any baby, I time, inspiratory time is equal to the gestation of the baby. So if you have an inspiratory time of the 30-weeker baby, start 0.3 seconds. The 35-weeker babies start 0.35 seconds. Term baby 0.4. Extreme premise 24-weeker, 25-weeker 0.24, 0.25. Okay. So here the physician or clinician is deciding the inspiratory time of this baby. By this time, this is called time cycle ventilator mode. So after this 0.35 seconds, then for example, 1.5 seconds, as we said for the previous 40 breaths per minute, 1.5 seconds for each breath. We have a term baby, 0.4 seconds for the I time, 1.1 seconds will be for the expiratory time. Okay, so the machine will calculate based on the rate and the inspiratory time you set, how many cycles it has to give. Okay, but in a flow cycled mode, once the set volume of gas is delivered during the flow cycling, so you decide the amount of gas that need to be going rather than the time. Okay, you're saying this amount of flow has to go in. Either flow has to be decided by the pressure or flow has to be decided by the volume. If you are on the volume ventilation, you can say this much amount of volume I needed. The machine will decide how much amount of airflow is needed to achieve that volume. Or if you want to set amount of the pressure controlled ventilation, you set amount of pressure, the machine will decide how much more amount of flow. And also decides how fast it has to go, how slow it has to go to achieve the required pressure or volume based on the compliance of the lung. Okay. In a flow cycle mode, once the set volume of gas is delivered during the flow cycling, the inspiratory flow will slow down and the ventilator ends the inspiration. Okay. So then the concept of limiting the inflation. Once the inspiratory valve opens after inspiratory synchronization, the ventilator will limit the delivery of gas based on the modality of ventilation, whether pressure or volume. Okay, this we just discussed. In volume ventilation, the inspiratory gas flow is controlled. Gas flow is controlled, whereas in pressure ventilation, the peak pressure is altered to limit the gas flow. Okay, so in the timing of this inspiration and expiration, which is mainly the limiting the inflation, is dependent on which mode of ventilation are you pressure controlled, volume controlled, or time cycle or flow cycle. Okay, makes sense, I think, so far. So if you have any questions, I would like to answer here before I move on, because the terminology can be quite confusing. If anyone, give 2 minutes, if anyone wants to put any question in the chat. Otherwise, I'll continue. So basically, we need to remember pressure controlled ventilation, volume controlled ventilation, what is the triggering means, what is synchronization, and what is the time cycle ventilation and flow cycle. Okay, I think I'll continue if that's okay. So next comes to spontaneous, or like just want to you bit more clarity about this ventilations. So normally, if it's a spontaneous breath, looks like something like that. Inspiration, which is a negative flow, and expiration, which is a positive flow. So mechanical breath, everything is positive. Yeah. So spontaneous breath looks something like that, and then ventilator breath, artificial mechanical breath looks something like that. So if it's in the similar graph, if for example this we decide as a physician, this breath need to be supported. Okay, we set the trigger, we set the pressure or the volume, and we set the inspiratory time, how high it needs to go, how much it needs to go. So the baby started taking a breath. The ventilator decided to notice that baby is in the inspiratory phase, and baby's inspiration is triggered. This is called assisted breath. So when the breath is being triggered by the baby, it's called assisted breath. For example, the baby is paralyzed or baby doesn't have any respiratory drive. Okay, that is a breath that is controlled by the machine. So this breath is not triggered. This is a triggered breath. So coming to pressure modes of ventilation, the pressure controlled ventilation, common come across SIMV, SIPPV, or PSV. So in SIMV mode, which is synchronized intermittent mandatory ventilation. Okay. So basically, as a clinician, we set parameters. As we said, is pressure controlled ventilation. First thing we need to identify. So we need to set the amount of pressures. Peak pressure, for example, 20. Positive and expiratory pressure of 5. So those are common settings we start for most of the newborn babies, around 18 to 20 BIP and peak of 5 to 6. Okay. And then you set the inspiratory time based on the gestation of the baby. And you decide the rate. What normally starting rate would be 40 per minute. For example, you set a PIP of 20, peak of 5, and the rate of 40 for this baby. So the machine knows every 1.5 seconds it has to give a breath. Okay. In this 1.5 seconds, if the baby triggers the ventilator, it supports that ventilated breath. Okay. And within another 0.3 seconds, baby decides to have another breath. So baby is tachypneic, for example, baby's rate is 60, but you want your rate set rate is only 40. Okay. So baby decided to breathe every second, but as a clinician, you are saying every 1.5 seconds you need to give a breath. Yeah. So machine is decided to give only every 1.5 seconds. Yeah, that's the maximum it does. So this, for example, this is the breath that is triggered, assisted ventilation, breath completed, and the next breath happens within 0.3 seconds or 0.4 seconds for this baby. So the machine decides, okay, I was told only support every 1.5 seconds, only 40 breaths per minute. This is an extra breath. I don't need to support this. So this is the unsupported breath. This is the baby's own breathing causing inspiration, high time and expiration. And then the machine decides from the end of this expiration, another 1.5 seconds to give this breath. Okay. If the baby has another breath in between, baby doesn't support. So the machine supports only 40 breaths per minute in these settings. That is means every 1.5 seconds it supports a breath. If the baby breathes more than that, it is not supported. Okay, that is the main difference that we need to understand in this mode of ventilation. So the rate we set is the number of supported breaths, and the same rate is also, for example, baby is not breathing 40 at all, baby is breathing only 20. 20 will be supported by the baby, supported by the ventilator. Remaining 20 will be, as we said in the previous term, controlled ventilation. So 20 supported breaths, 20 unsupported breaths. The total 40 breaths are delivered for this baby with that clinician decided settings. That is the same mode. Yeah. So the rate here either is a backup rate or the number of breaths that are being supported by the ventilator. Next mode we go to. So if I want to show a video how the SIMV mode looks like. So SIMV mode, as we see, as a clinician, we set a pressure of 20, peak of 5, the term baby inspiratory time of 0.4, the rate of 40. Okay. So this is the orange. Orange color is the triggered breath. So here are most of the machines to give you information on the side. So how many breaths, total breaths per minute, and how many are triggered breaths out of it. It gives you information. So the baby is breathing more than the set rate, it can get the information from this machine here. And also it gives you the tidal volume, it gives you the amount of leak. Okay, just come back to why I'm mentioning this. So every time orange breath, that means the baby is taking a breath, baby is triggering the breath. As you can see, this breath is supported, this is unsupported. This is supported, this is unsupported. Supported breaths, unsupported breaths. Yeah. So only 40 breaths are supported by the ventilator with the given settings. The remaining breaths the baby is going to take are unsupported. That means baby's own breath. The baby is not taking any breathing at all. Machine will deliver at least 40 breaths. So next mode coming to SIPPV, which is synchronized intermittent positive pressure ventilation, which is also called PCAC, assist controlled ventilation, or patient PTV, patient triggered ventilation. It's all the same ventilation with the different names by different brands of the ventilator. Okay. Here, the main difference between the SIMV and SIPPV is that every single breath is supported in this mode. Okay. So you decide the PIP, you decide the P, you decide the I time, and you decide the rate as well. So you set the rate. So it's the PTV, SIPPV mode, 20/5, the same baby actually. So I 10.4, term baby, backup rate of 40. Okay, if you watch this mode, every single breath of this baby is being supported. So although we set a rate of 40, 78, 80 almost are being supported by the baby. So in patient triggered ventilation or assist controlled ventilation, every single breath is supported by the ventilator. The 40 rate is just a backup rate. Okay, that's the main difference between the PTV and SIMV. In SIMV, the rate is the rate of supported breaths. In PTV, the rate is a backup rate. Okay, so why is it important for us to know? Most of it got confused or missed. For example, you're on this SIMV mode of ventilation, or sorry, PTV mode of ventilation. Your baby, you're in these settings, 20/5, rate of 40, and you do your blood gas showing severe hypocarbia, pH of 7.5 with the CO2 of 20. That means the baby is hyperventilated. You want to wean the ventilation. If you want to wean the ventilation, one of the common things we want to do is decrease the minute ventilation. How do we decrease the minute ventilation? Either you can change the PIP or you can change the rate. If most common tendency people tend to do similarly in this setting, you have an FiO2 of 65%. You don't want to decrease the pressures much. You want to go and change the rate. You decrease the rate from 40 to 30, so that you want to avoid the hyperventilation, hypocarbia for this baby. But actually what you are doing, you're only decreasing the backup rate. So if you decrease the rate to 30, but still because baby is breathing at 80 per minute, the ventilator continues to deliver 80 supported breaths. Okay, that's the most common pitfall as clinicians we all do. If you are weaning the baby on a PTV mode or SIPPV mode, either weaning the rate, or increasing the rate, you need to make sure that actually you are adjusting the rate, either changing from PTV to SIMV, yeah, or changing the PIP rather than the backup rate. So for example, the given gas of pH of 7.5, the CO2 of 20, with these settings, I want to wean this ventilation, I would switch to SIMV mode from PTV mode. Between PTV on mode and SIMV mode, when we starting ventilation, it makes more physiological for us to support each and every breath of the baby. Yeah, because obviously we don't want small babies, some unsupported breaths which they have to breathe through the ET tube, which doesn't make physiological, doesn't make sense. So always better to start with assist controlled or PTV mode of ventilation, patient triggered ventilation, and then depending on the blood gas and other parameters, slowly wean the ventilation settings. So SIMV is the mode mainly for the weaning mode of ventilation, and PTV is main for the starting mode of ventilation or high ventilation. Before I move on, any questions, anyone? Okay. So next one, coming to pressure support ventilation. The two previous modes we talked about SIMV and SIPPV or assist controlled ventilations. Both these two modes of ventilation are time cycled ventilations. Yeah. So the time cycle, we are deciding the inspiratory time for this baby. The next more physiological mode of ventilation would be the pressure support ventilation. Pressure support ventilation, basically, although terminology doesn't actually completely translate into the physiology of this ventilation. Pressure support ventilation, PSV mode, PSV, we have to remember the word PSV. Here, it is a flow cycled ventilation. Yeah, okay. The inspiratory time, we only can give you maximum time, and the machine and the baby together decides how much time is needed for the inspiration to achieve the desired pressure. So you are saying this machine, I want pressures of 22/5 with a rate of 40. I am giving a maximum time of 0.4. As you can see, each breath, the inspiratory time changes. Depending on the compliance of the lung, the inspiratory time changes. In pressure support ventilation, each and every single breath is supported. Basically, it's an advanced mode of ventilation, an addition to the PTV ventilation along with the rate. Inspiratory time is also decided by the baby. Clinician can only decide PIP and P. Okay. If you compare the last three modes, SIMV, as a clinician, we are deciding PIP, PEEP, I time, and the number of supported breaths. Rate. All four are being decided by the clinician. In this mode of ventilation, we are also deciding the PIP, PEEP, and inspiratory time. Rate is decided by the baby. If you come to the pressure support ventilation, as a clinician, we are only deciding only PIP and PEEP. Baby will decide the rate, baby will decide the inspiratory. Okay, so pressure support ventilation seems more physiological, and because the flow cycled ventilation, it prevents the trauma, volume trauma, less desynchronization with the baby, and less chance of lung injury. But pressure support ventilation is only available on the latest generation of ventilators, not available on the previous modes of previous generation ventilators. Next comes to that's the three modes of pressure controlled ventilation: SIMV, SIPPV, and PSV. Then coming to volume controlled ventilation. In volume controlled ventilation, cycling is controlled by delivery of set tidal volume. So two terminology you need to remember: volume controlled and volume targeted. Volume controlled ventilation is slightly different from volume targeted ventilation. Both are volume ventilations. Whenever we say the new generation or the evidence, all coming from the volume guarantee, not from the volume control. In the volume controlled ventilation modes where most of us use, cycling is controlled by the delivery of set tidal volume, which is similar in both the settings. But in volume control ventilation, the volume of gas delivered into the proximal end of the circuit, not the volume of gas entering the lungs. So these machines this mode can only detect the amount of gas delivery into the tubes, can't exactly detect the amount of gas reaching the lungs. Basically, these are the volume controlled ventilation, which are old generation ventilators where the flow sensor was inside the ventilator. So volume controlled ventilation is not same as volume guarantee ventilation or volume targeted ventilations. Okay, so volume controlled ventilation might be slightly better than pressure controlled ventilation, but not the right mode if you have a right ventilator, because it is affected by the complaints of the tubing, the compressible volume of the circuit, the humidifier, leak around the tube. All those things cannot be adjusted in the volume controlled ventilation. Next comes to volume targeted ventilation, which is also called volume guarantee or targeted tidal volume. Okay, so tidal volume targeted ventilation is designed to deliver the targeted tidal volume by adjusting the inspiratory pressure. For every breath delivered, tidal volume is compared with the set tidal volume. So how does it happen? Operator selects a target, a set, the VT set. So I am saying my baby, I need 5 ml per kilo volume targeted ventilation. Okay, I'm telling the machine, okay, this is the maximum amount of pressure you can give. I don't want to give more than that. You can set maximum PIP. PIP is constant, inspiratory time is constant. So ventilator delivers a breath and then measures the tidal volume. If the tidal volume generated in this breath is equal to the set tidal volume, the first breath is, it just gives it based on the settings you have given here. Okay, and then the machine detects how much volume is generated delivered to the baby. If it is equal, continue same PIP. If the tidal volume of this breath is either less or more, it adjusts the PIP accordingly. Okay, so in the volume guarantee ventilation, the machine decides the amount of pressure needed to achieve the desired tidal volume for this baby. You want to deliver tidal volume of 5 ml per kilo, and the machine first breath it gives with the pressures of PIP of 20/5 with inspirator of 0.5, and then for the previous, if you look at this this video, for example, in these settings, I want to add volume guarantee to this ventilation. I'm giving this settings 22/5 with a rate of 40. First breath will be 22/5 with tight time of 0.4. Okay, and then the machine can identify how much volume is delivered to these babies through the flow sensor, which is closer to the baby. Okay, so if the volume I want is 5 ml per kilo, the volume delivered to this breath is only 3 ml per kilo. Next breath, the PIP is increased by 10%. Okay, so the pressure of this breath is based on the volume of the previous breath. Okay, so every breath the machine senses the tidal volume and adjusts the peak pressure for the next breath. Okay, and every time the adjustment is only done by 10%. Okay, so by this mode of ventilation, if we're going a volume ventilation with PSV, for example, PSV plus volume guarantee, it's got TTV ventilation. If you have PSV with TTV, so as we said before, in the PSV ventilation, the rate is decided by the baby, item is decided by the baby. Now we are saying even the peak inspiratory pressure is decided by the baby indirectly by the compliance of the lungs. Yeah, only PEEP is the only thing the physician is going to be adjusting. Okay, so pressure support ventilation plus volume guarantee ventilation is most physiological way of ventilating a baby. By this mode, the clinician and the bedside nurse and the respiratory physicians have less work and less things to do. You only tell, okay, my baby wants 4 ml per kilo or 5 ml per kilo. I want the PEEP of 5. Okay, and the machine does everything else for you. Okay, and then the machine either increases the pressure, decreases the pressure based on the baby's lung compliance. Okay, just to comparison all the modes again, SIMV all are decided by the operator in SIPPV modes. So breath is taken out by the baby or the ventilator, or the like breath, how many breaths, the supported breaths is decided by the baby. In pressure support ventilation, inspiratory time and breaths both are decided by the baby. In volume guarantee ventilation, along with all these two, even PIP is decided by the baby. Okay, so out of all these four modes, volume guarantee mode is more physiological. So volume guarantee mode goes along with the PSV. So you can have SIMV plus volume guarantee. You can have SIPPV with volume guarantee or PSV with volume guarantee. Okay. Next comes a special hybrid model called SIMV plus pressure support. That's another mode I want to discuss with you today. So in SIPPV mode, each and every breath is supported by the baby. For example, you want to set the rate of 20 by 5. Sorry, ventilator settings, PIP of 20, PIP of 5, rate of 40. Okay, and we have a gas with hyperventilation. You want to wean the ventilation. You want to change from SIPPV to SIM. Okay, so automatically, and you can decrease the rate. Here the rate was 40. You can say the rate is 30 here. Okay, but the 10 breaths suddenly going from pressure of 20 to the baby's own breaths, the unsupported breaths are completely unsupported. Yeah. So where the concept of pressure support is coming, the new modes of ventilators. Here in SIMV mode, only few 40 breaths are supported by the baby. This is a supported breath, this is unsupported. You can add SIMV plus pressure support, the PSV setup is called pressure support. Once you switch it on, okay, it tells you how much pressure support you want. You might not want 20, but I want only 10. You can decide. Rather than completely weaning off from 20 to 0, no support, you can say, I want to wean from 20 to 10. So 40 breaths will be supported with 20 by 5. And the remaining unsupported breaths is not completely unsupported, they are partially supported. PS, pressure support. The PS also stands for pressure support, but easy to remember. It's a SIMV plus partial support, which is somewhere between SIMV and SIP. Okay, so you can still use SIMV plus pressure support plus volume guarantee. Okay, this is a supported breath, partially supported breath, which is different from the previous thing we have seen, where it's not supported. I think it's already too many terminology here. I think I'll put next other modes in next session. High frequency, we're going to talk about non-invasive ventilation, brief touch on jet ventilation and NAVA. Okay, I think I'm ending this session for tonight. If anyone wants to ask any questions, please feel free. It can be quite confusing, but one thing I want to stress, improper use of ventilator leads to physician-induced lung injury, also called ventilator-induced lung injury, which we want to avoid. If all of us can understand the modes of ventilation, depending on the compliance of the lungs, depending on the mode of the pathophysiology we are dealing with, we can provide appropriate ventilator or ventilation mode for this baby. Any questions?
Dr. Ranjit, there is one question on the group, which was, would PTV or PSV be the weaning mode?
No, PTV and PSV are the starting modes. SIMV is the weaning mode. As you see, PTV and PSV are every breath is supported. Obviously, it is the starting mode where you want to support each and every breath of the baby. Once you want to start weaning the ventilation, so you want to support some breaths, you want to support some breaths. That will be unsupported. That is SIMV mode. So PTV.
So I think now with this we can conclude our session. There are no other further questions, Dr. Ranjit. Okay. And I think it was very, again, I'd like to reinforce that it's a very difficult topic, very confusing. but you have made it very simple.
Thank you.
Great job.
Yeah, thank you very much. Yeah. Have a good night, all.
I will update you, all of you, about the session 3 of ventilation, and kindly read about it, and you will be having a lot of questions. So feel free to put in or send me directly. Thank you, everyone. Thank you, Dr. Ranjit.
Thank you. Thank you.